Six, five, four, three, two, one. Over to Rohan.
Good evening, everyone, and welcome to today's webinar by Project StepOne. The topic for today is COVID preparedness via lessons from India and abroad. A quick introduction about Project StepOne. Project StepOne is a non-profit that was set up in March 2020 to fight against COVID-19. The intent is to keep people indoors and help them with their medical and healthcare needs by connecting them remotely with a doctor. Today, Project StepOne's Sathi Telemed Helpline is one of India's largest telemedicine efforts, partnering with 12 states and adding a state every week. As a collective effort of more than 6,000 volunteer doctors and 100 technologists, entrepreneurs, operators, all coming together, we are able to serve people absolutely free of cost by answering more than 30,000 calls every day. With that, I would like to start today's session and introduce our moderators and panelists from PediSTARS. First of all, let me thank all of them for taking out their valuable time and joining us here. Today's session will be moderated by Dr. Sujata Tyagarajan, who's the founder and secretary of PediSTARS and consultant pediatric intensivist at Rainbow Children's Hospital. We also have Dr. Rakshay Shetty, who's the founder and president of PediSTARS and the head of pediatric intensive care services at Rainbow Children's Hospital, Bangalore. We also have Dr. Gitanjali Ramachandra. She's the vice president and co-founder of PediSTARS and a pediatric intensivist at Hyderabad. Dr. Vijayanand Jamalpuri, joint secretary of PediSTARS and a consultant neonatologist at Rainbow Children's Hospital, Hyderabad. Dr. Hulu Sharif, professor of anesthesiology and certified healthcare and simulation educator, and Dr. Vaibhavi Upadhyay, a clinical lead in simulation, anesthetologist at Dinanath Mangeshkar Hospital, Pune. With that, all over to you, Dr. Sujata.
Thank you, Rohit. Good morning, everybody. Good evening, everybody. On behalf of PediSTARS, I welcome you for this webinar, and I thank Project StepOne for their wonderful work that they're doing and giving us this opportunity to, present this webinar jointly to everyone. On behalf of PediSTARS, I want to share some experience of how we managed our COVID preparedness within India. And I want to share a few slides as well. So let me start off with this one. So to set the scene on COVID preparedness, some of the things that we had was, we knew from China that, it has started off in December itself, but we had very little protocols to understand much about this illness, how to prepare and what to anticipate. So the first things we did was try to get some guidelines put through, and that took some time for us. And then we created some simulation scenarios that we shared with our facilitators within India. And then we did something called Simulathon, which is between April 20th to May 20th. We requested all our facilitators to conduct these simulation scenarios within their centers to see how the COVID preparedness, could occur in their centers. And then we also took some input from across the world through our survey. We asked all our facilitators as well as people from across the world to answer our Survey Monkey 7 or 8 questions, to understand what is the, lessons that they learned and what challenges they faced, how many facilitators were involved. I want to share a little bit about these scenarios now and the results. So if we look at it, we had 37 centers from 17 countries or 6 continents globally who replied to our survey, and 36 centers from within India. If you can see, there's a broad representation from every country, every continent. We had majority of them from the USA. The participants from across the world was something like 828 nurses. So nurses were predominantly trained across the globe, and then a little proportion of doctors and then interprofessionals. The number of facilitators, as you can see, majority of them were doctors. I want to share with you a little bit about our Indian scenario. So if you look at India, about 36 centers participated, and of them, we had predominantly almost nearly 550 of them being doctors, and a little less about were the nurses, and very less was the support staff, but still a significant number. And our facilitators was nearly half of what we saw across the world. And going a little bit into details, the in-situ simulation was predominantly done in almost, so the blue bars are all the Indian data, and the red bars are all from across the world. So if you can look at the professionals that were trained, you can see, the proportion of interprofessionals was significantly higher in the rest of the world. You see the profile of the facilitators. Rest of the world had significantly higher number of facilitators in the left lower graph that you can see. And if you look at figure 3, the location of in-situ simulation sessions, expectedly, emergency department and PICU were predominantly the areas where we did our in-situ simulations, and we had the opportunity to do that as well. And then we asked all the participants of the survey whether they had the ability to manage COVID patients following this simulation session or the training that they had given. And if you can see, majority of them in India felt very confident, and as per the rest of the world. In the rest of the world, they felt a few centers, really 8 of them felt they were not sure. And some of the things that they had mentioned were, about the opportunities for them to become COVID centers. That was the reason why they felt they were not sure, not because of the simulation that they did. So I want to just kind of zoom in into this particular slide and invite upon Dr. Rakshay, who is my colleague from Rainbow Children's, and also who is the president of PediSTARS. So Rakshay, we in India seem to have done a lot of in-situ simulation in emergency department and PICU predominantly. And I know you were very actively involved in motivating others also, and setting up some protocols and creating some scenarios from within India. I wanted to share your experience and tell us more about, the key learning points. So over to you, Rakshay.
Thank you, Sujata. Just give me a moment so that I'll share my slide. All right, so can you see my slide?
Yeah.
Yeah, okay, excellent. So like what Sujata mentioned, what I thought was I'll just take 5 to 10 minutes or so to share our experience during this whole COVID season about how do we go about preparing ourselves for a COVID onslaught. So our experience with PediSTARS over last 8 years, trying to inculcate about using simulation as one of the tools for quality improvement has, when we talk about people, a lot of challenges are related with time and availability of equipment. So for us through PediSTARS, when we try to use advocate simulation, it was mainly to figure out how do we solve clinical problem using simulation. For most, when we talk about simulation, they would think, simulation is mainly an educational tool. It is, of course, a great educational tool. And you need a very big simulation lab. Yes, there are certain advantages of having a simulation lab. But what about role of simulation for someone who's working like an intensivist like me in the hospital? How can I use simulation and show its power in terms of improving patient outcomes? And that was a very important question. And oftentimes people have struggled. Many of us who work in corporate sectors, our challenge is convincing the administration about investing onto simulation, in terms of time in terms of buying certain equipments. And COVID, for that matter, provided a perfect platform to show administrators, how you can utilize simulation to ensure that you can show a value for simulation to the administrators. So um, when we started off with the beginning of COVID season and lockdown, there was a lot of apprehension among everyone about how are you going to handle this kind of COVID patients. There's a lot of anxiety among nurses, healthcare professionals. Are we ready yet? What do we do if we get a COVID patient? Does the hospital get shut down if we get a COVID patient? What's the risk of ourselves getting exposed? So there was a lot of anxiety around this, and we thought simulation really helped us in this particular context about looking at the protocols what we created, testing them in real scenarios. And to ensure figuring out any problems or challenges, and also as a confidence boosting measure among the healthcare workers. So from that context, we use simulation. None of us have expensive simulation equipment. We are not working in any simulation lab. So from that context, I just want to share this experience. A lot of what we did was in the hospital using the equipments, what we did, and figured out how do we get best out of simulation here. So this framework I particularly like, which has been propagated by Dr. Peter Weinstock, using various simulation zones. And what you see here is zone going from 0 to 4. Now, this is very important for us to understand, because when we talk about simulation, many times we feel that having a very high technology simulator, that's the way to run simulation. Of course, there are a lot of advantages to that, but many times it depends upon what are we trying to achieve out of this. So many times a zone 0 simulation, when we say zone 0, we're talking about skill training, someone trying to learn how to put an IV, how to intubate a patient. But in the context of COVID preparedness, learning how to wear a PPE or remove that PPE, it becomes a very skill oriented thing, and it becomes a zone 0. A zone 1 would be, in the clinical context, for example, how do we prepare ourselves in terms of donning a PPE in someone who's having respiratory distress. So it's more of kind of clinical skill development. A zone 2 is something most of us are familiar, in terms of responding to a mock code. So more of when we talk about zone 1 to zone 2, we are really looking at how and what, more of a process kind of testing our protocols are working well or not. Zone 3 and zone 4 especially looks into why things did not happen. So we are focusing more into, we're not having much of a knowledge aspects about people knowing the protocol or not knowing. We know that people know the protocol, they're all quite skilled, but we want to figure out why, despite knowing the protocol, why despite having highly skilled professionals, things don't happen the way we want. So we are looking more into human factors dimensions. So oftentimes we think, this is the epitome of simulation, and if I'm a skilled professional, I should go to zone 3 or zone 4. It's not always true. So many of us, despite being skilled, might need still a zone 0 kind of a training, where we might want to learn how to actually wear a PPE properly or remove a PPE properly. So when we designed our simulation with regards to preparedness, this framework really helped us. So from zone 0 to all the way to zone 3. So let's, I'll just share for the next couple of minutes about certain examples about how we went about it. Now, for example, this scenario, what you're going to see is essentially about training people about how do you actually wear donning and doffing PPE. So we prepared a team. We ensured that the PICU staff, the doctors and nurses across the hospital learned how to actually wear PPE properly. And then what we gradually did over time is we kind of started timing it. So kind of created a competition in the ICU who takes minimum amount of time to wear PPE correctly and doff it, both donning and doffing correctly. So then subsequently, we went on to testing our protocols, because now the whole flow of the hospital had to change, because we have to create a triaging system where we can identify COVID versus suspect COVID versus non-suspect patients. So we ran the whole process in terms of how would the triaging happen, where would the triaging happen, what would happen if it's a sick patient, and then, so So this is again was quite useful for us because a lot of our process testing in terms of triaging place for a non-sick versus sick patient, and then where should they be kept, and how do we ensure that the least amount of exposure to the nearby people happen. So when we started off, it helped in refining our protocols quite significantly over time. So then subsequently, about how do we actually transport these patients? So to the ICU. Again, there were a couple of lifts in the hospital. Which lift is more safer? Which lift the room carries minimum risk, exposure risk to attendants? How do you cordon off the area? How do you sanitize the lift afterwards? All of those things we could test in real time, and also ensuring that people were wearing PPE during their journey. So we could test by using in-situ simulation. And then coming about how do we manage a patient who is already in ICU, So this is where zone 2 zone 3 kind of thinking helpful to us. Where, where essentially we look into how do we ensure that we intubate safely? Because remember, when we're talking about COVID intubation, we're talking about minimalizing aerosol exposure, which means you require less number of people. Take certain viral fitness during intubation. Doctors being inside the room, people wanting to be outside and then doing. So this preparation really boosted our nurses' confidence that yes, this is certainly possible to do with less number of people inside. Then subsequently, we were also thinking about how do we do a CPR for this group of patients. And again, having a team leader standing outside the room, minimum number of people inside, ensuring that we don't bag, we intubate directly using viral filter. So, and how do we, does a monitor look? There's a concern about running these scenarios also is a lot of us are covered completely in a mask and goggles. Our communication, non-verbal communication becomes the issue. Your voice needs to be louder. So many of those things, they come to zone 3 kind of a simulation training. And it really helped us to filtering out protocol and refining the protocol quite a lot. So in the end, I just want to conclude by saying, this provided a perfect platform for us in many ways, because when we entered a lockdown phase, many of us actually got a lot of time because the clinical work actually came down, and it helped us into building scenarios. It was provided as an opportunity where we could get some buy-in from administrators, because we could call them, we could show them, this is how we can test our protocols, and kind of facilitate our argument with an administration to invest a bit more on simulation facility, invest a bit more on training of trainers, so that you could have more talent pool in terms of using simulation to in the organization. And when I spoke to a lot of people who've been struggling over the last few years and trying to impress simulation, I think this opportunity certainly provided us with a lot of advantage to put forth your advocacy for using simulation in the hospital. So with that, I would just conclude my talk, Sujata. Thank you for this opportunity, for allowing to share our experience about how we went with using simulation, with not having much of high technology mannequins and being full-time clinicians in the hospital. Thank you so much. Sujata, we can't hear you.
Yeah, thanks, Rakshay. So one of the key points that you just highlighted on is about how we got the administration on board and how we could kind of impress upon how simulation can be done in situ. I want to just look at this chart again. And if you look at it, the NICU, we seem to have done more in India than the rest of the world, at least according to this survey. So I want to just ask Dr. Vijayanand from Rainbow Hyderabad to just look at it. I mean, India has a very high birth rate. We need to be like really, on board and make sure that we are safe. So how did we do in India, and do you want to share your experience of how you prepared the NICU team?
Sure. Thank you. Yeah, you just Sujata. Oh, right. Yeah, thank you. Good evening, everyone. Thank you, Sujata. Sujata and Rakshay already mentioned how this preparation was being gone. And I think with this COVID pandemic, there is nobody, no clinician for that matter, nobody across the globe is not scared of. Having said that, neonatologists were a little bit relaxed to start with. Well, in NICU they don't, but they do. Then we realized that the COVID positive mother can contribute to our ICU. Then we thought, oh, we need to get ready. So I'll just share a few ideas and how did we prepare, what we learned through this exercise. I can't generalize to India, but certainly for our cluster of Rainbow group of hospitals, and how the simulation helped us to prepare for the neonatal care provide in this difficult COVID time. Okay, so first of all, yeah. So what is the objective? The objective of our simulation process or learning process or program was be able to provide the typical routine neonatal care, but with uh, with the adherence to the what is special to the COVID was the infection control guidelines, so that we don't get infected ourselves and also the people who are around the baby looking after that means other patients as well. And the challenges to provide such neonatal intensive care or neonatal care while adhering to these guidelines. Um, and what did we do? We did a needs assessment, like we need to know what is new for this pandemic to provide the care, what new skills we need to acquire, and then how do we all synthesize and assimilate that to the real practice to deliver the care, which is of course teamwork. And so we looked for all the national and international guidelines and come up with our own SOPs, and of course the guidelines for our units, and which has incorporated a lot of simulated pictures so that people can understand easily. So it started from the sharing the knowledge, which we shared with across all the healthcare professionals who will need to know. And then we come up with the skills training. As Rakshay nicely pointed with regard to sim zone, so however senior they are, so for new thing, they are all zone 0 or zone 1 if at all. So we decided that we'll practice. But one thing here is like practice with what? Because that time when we started this preparation and there was a scarcity of PPEs across the globe, you are wearing from New York and UK, people are just wearing the surgical mask and need to do because there are hardly any. So we decided that we don't want to waste them. But again, it's a fine balance of using real PPE and get that real feel at the same time, not to waste the resources. So we sort of use some surgical gowns, some customized stuff, and but once they get to the mastery level of, then we use the real ones for the people who are more tend to go to that situation of using PPE. So we have done some videos to share them so that they can watch before they practice both donning and doffing. So what did we learn? As I said, as Rakshay already mentioned, the key thing in donning and doffing is again the safety of the healthcare provider. There were issues which we could find clearly. There was the breach, and there were so they needed to do safely so that they don't contaminate themselves. The other main issue, which again Rakshay nicely said, was a time taken. Initially, when we started, it was up to 10 minutes. But imagine in case of an emergency, it can be too late. So we decided that we practice. We didn't do any competition as Rakshay did, but we practiced so that we can cut down to 2 minutes. But having said that, in a potential areas like emergency areas, there's already person who is already in PPE all the time so that we can save that time. And then, but during the PPE, but whatever it takes, 30 seconds or 1 minute late, but the safety of the healthcare provider is important. We emphasize to our healthcare professionals. And then we come up with some a simulated PPE like this simple N95 mask. But bear in mind, we did not use for everybody. We initially use, once they come to the mastery level, we use the real ones as well. Okay, so and TPs and AmbuVac, the national and international guidelines suggested using HEPA filters. So we use the HEPA filters for preferably in neonatal resuscitation We were asked to use the ambu bag for because the aerosol generation, if you use the TPs, is more. But having said that, but it's a pre-term, you need to use the TPs. So we practice them and with our learners. And then, like already Rakshay mentioned, the aerosol exposure protection boxes. The initial one was too big and it was not able to maneuver for us for the little babies. So we customized it. And what did we learn with these? Some of the skills is the customization of part of the equipment we use for our babies. And also one of the key thing, because in our unit, we don't use the neo bars or the fixators here. So we were using the tape. So this was a real challenge. It may sound silly, but the real challenge to fix the ET tube. So we come across with the not to peel off the cello tape on the tape, and we practice so that we can do it even with the gloves. And then we went into the familiarization of the environment and the scenario training, which is sort of zone 3, you can say. And so we showed where we are going to take in all the learners and the healthcare providers who are going to be involved, where we are going to do. And we have a special box where we provided all the equipment required for the resuscitation of these COVID babies. Okay. And then we designed the scenarios, and for mainly 4 situations. One is neonatal resuscitation after birth, and a baby which whom we looking after, but they got sick suddenly, and somebody who is walking into the ER with a newborn baby of the suspected COVID mother, and also transport situations. So I'll just share a couple of examples. This is one of the such scenarios. This trainee was getting ready for a delivery of COVID mother, but again the patient flow, the flow for the healthcare provider is different. So they need to go in a special route. All we marked and several times. And then there's a scenario where the international guideline is specific that, yeah, just to show just a flavor, I'm not going to run the scenario. Okay. So here, the one trained healthcare professional should be attended for neonatal resuscitation, who is trained in neonatal resuscitation, at least one in uncomplicated, in a complicated, or where the problems are affected too. So we practice so that with the limited people, they need to. One of the challenges, I'll just tell the challenges. Another scenario, working in a NICU dedicated, or the isolated data dedicated to look after the NICU babies, suddenly getting deteriorated, what you do? And this is another just a flavor of the case.
To help this baby. Is that clear? Birth weight is 3 kilos. Okay?
Okay. So then what we will learn? So here the challenges were examination and assessment was difficult with the auscultation. So we said, okay, there should be alternative methods like ECG leads to get the heart rate, and also alternative methods of checking the tube and so on. So we ensure that they are always there. And as per NRP 2015 guidelines, ECG leads are not mandatory in all the cases. And the limited team members with the PPE, so that they need to understand that there are only 2 people. The second person, if uncomplicated one, will be waiting there, and they need to understand that they need to deal on their own. So when the 2 or 3 people, because usually if it is significant resuscitation, there are several people can come across, but in this situation, no, but they need to deal with that. And there were some communication issues, like they can't understand easily. So they decided that they will have some sign languages or speak slowly when they are giving the instructions. And also time taken for PPE donning in case of emergency. In a known, the delivery is going to happen, we know the time, we have time, that's not a problem. But the baby who is got sick, there's only one person helping there, but other person to come in. So again, with the practice, we could come down very efficiently. Okay. And also there are breach of usage of certain protective measures, and where we reminded the people that you have to use, we paused and discussed and so on. So in summary, what did we do? We did the majority of the simulation in situ, and the mannequins we used, as Rakshay mentioned earlier, was the middle technology, but we created the environment with a high fidelity. And the various DPP methods were used. For technical skills, we used rapid cycle, deliberate practice. For team training, majority was pause and discuss and plus delta, a little bit of advocacy inquiry. So this made us to sort of feel that we were ready for the COVID pandemic to look after the sick, vulnerable little babies. Thank you very much for listening. Over to you, Sujata. Can't hear you.
Dr. Sujata, you're on mute.
Yeah, thank you. So, Vijay, you just highlighted how the different zones were approached and the challenges you had, how we had to customize and do things. I want to move on to the next important finding we had from this survey. And let me just get that slide across. So if we look at this slide, what we have is predominantly, a big difference in the interprofessional training. If you see, the rest of the world seem to have done quite well in getting their interprofessional training sorted out compared to India, and the gap seems to be much wider. I don't know whether it is because there was a scare of COVID, whether we are just traditionally used to training doctors and nurses, but I just wanted to understand from Dr. Lulu, because your center seemed to have done well in terms of getting the interprofessional training sorted out according to our survey. And I wanted you to share your experience and what specific methods helped you amidst the staff conservation that we had, amidst lockdown, amidst, the quarantining that was going on. So kindly just share your experience, Dr. Lulu.
Yeah, thank you, Dr. Sujata. And first of all, I'd like to thank the team StepOne and PediSTARS for giving our college an opportunity. So I'm going to share an experience with you what we had at Father Muller Charitable Institutions. We're in Mangalore, and unlike what Vijay and Rakshi presented, we are not in the corporate side. We're a medical college, so we do have the same challenges and plus a few more challenges due to the space and the number of staff concerned. So regarding the survey, I'm sorry, Sujata, we couldn't contribute much because our center opened only on 20th May, and that was the last day of the survey. But immediately after the center opened, we got in, the center opened and got people mobilized and our team. But the main issue, more than training, our concern was to test our revised policy, especially our Code Blue. So regarding your first question, how do you, get the staff support or interprofessional? Next slide, please. Yeah. So what I would like to tell you is it was not just after 20th May that we got all these staff involved. From the last 5 years, we've been doing hospital trainings. And even before our medical college skill and simulation started, we have involved our hospital staff, especially our housekeeping, our pharmacy, our lab. So it wasn't very difficult to get stakeholders, participants involved because it was kind of a routine. But like you said, our challenges were minimal staff requirement as per the government policies. So we had less staff. And also because of the quarantine, and taking in-situ, because our main concern was testing out the policies. And like I said, Code Blue revised policies, we all know aerosol generating procedures, you need a closed room, you need an isolation room. So what happens is our general wards, we are a 140-year-old campus, beautiful campus, big campus with remote locations, with around 900 plus nurses and 300 housekeeping. And we, to get all of them involved in a process of trying to shift a collapsed patient, providing the critical care, making sure that our healthcare staff are safe, and at the same time conserving our PPE. So these were our main goals. But then how to shift this collapsed patient to the designated ICU and then initiate our Code Blue team members, which will be waiting, was a huge challenge for us, starting from, remote locations of 4th floor, 5th floor, blocking the lift and then shifting on, en route chest compression. So that was a huge challenge for us. And so when we started out, next slide, please, Dr. Sujata. Yeah. So when we started out in the post-COVID, next slide, please, Dr. Sujata. Yeah. So when we started out, we were actually, I think the slide is not changing.
I think it is not moving.
Yeah. Okay, not a problem. So Do you want me to share from here? Is it moving? Yes, thank you. Thank you. You can see now. So what we started out in post-COVID was, first, like I said, revised policies need to be tested. So without In-situ, it's not possible to find out the system gaps. Like, if a trolley will enter our isolation room, maneuvering it, blocking the lift, involving the lift operator, the security personnel. So In-situ was a must. We decided to take the low tech, like how Vijay mentioned, but a high fidelity environment, which is obviously the environment they're working in, and the same corridors and the same lift. We try to use only our nursing staff which were on duty. And most of our nursing supervisors are a part of our simulation team. So they're very familiar with the simulation methodology. Once we took the videos, and because of the videos, we were very lucky because, you can edit the videos. We can use one PPE and then, cut and show that, okay, 3 people are there, airway compressor or the defib person use the same PPE and just change their badges with the same person. So all that helped us, when we took the video. And regarding training, since we are a medical college and we are routinely using virtual platforms for our undergraduate and postgraduate, that was kind of, easy for us because our institute has a G Suite and we decided to use the Google platforms for that. Interaction, yes, we were a little worried, especially with our nursing staff. Yes, thank you. With our nursing staff, because how will they take the virtual platform learning and how will we interact? That was a little concern. So like any other module, we starting from our needs assessment, we thought we'll complete and do the assessment and evaluation. So these are just, I'm sorry, because of center policies, we couldn't share the videos, but these are just few consented clips where we are same thing what Dr. Vijay and Dr. Akshay mentioned, the time taken to donning before cardiac arrest, what is the, every hospital has their own resource limitations and different infrastructure. So based on that, we had to revise, keep testing our policy. And finally, we came out with the video. Then like communication, gestures to be shown, to stay away during intubation or 2 minutes up recorder and during the defibrillation, all that, disinfecting the lift. So when we think about training, how do we just show a PPT and then, tell them this is what it all looks good on paper, but unless they see it, so that's how the videos helped us a lot. So initially what we did is we showed the videos first, they watched it, and then we played the video again with, the pause and perfect, like stopping them and then, having a discussion. And then we had a discussion and a question answer session, but we were more, anxious to know how the feedback was. So if you could move on to the next slide. And housekeeping staff also, like I wanted to tell Rakshay because he gave us the idea of donning and having a housekeeping staff in 22 seconds he donned, after he came just to shift transfer the patient. So regarding this feedback and evaluation, the center graph actually shows us the score of, we gave them a post test regarding the revised policies, what was new, what is the elevator phone number, which you have to call, what are the aerosol generating procedures. So they did fairly well. This is a result of our first batch, around 40 of them, and they scored really well. So we were okay with, okay, some learning has happened. And the feedback, yes, how were they comfortable with the virtual learning platform? How do they rate our learning platform? Do they want more sessions? So we are quite happy with what results we got. So we knew we were moving in the right direction. And with the help of a strong team, our Chief Nursing Officer and her team and task force, our Code Blue committee, multiple virtual meetings happened throughout to, reach the stage. We just began, we are still in the process. We have a whole lot more to train, thinking of now giving them hands-on, like how donning, doffing, and even then try to get one low-tech mannequin to the wards so that, they can continue the CPR and, just keep retaining the skills, what they have learned. So that is all I have to share, Sujata. Thank you so much.
Thanks, Dr. Lulu.
Yes.
If we just look at the next slide, there's a huge gap. The facilitators versus what we have in the world to what we have in India. But I must congratulate you, Dr. Vaibhavi. Your center seemed to have done the maximum number of participant training in India. I wanted you to share your experience to say, how is it that you managed in such a short span of time to actually train that many number of participants? So can I invite you, Dr. Vaibhavi, to share your thoughts?
Hello, Dr. Suja. Let me share my screen. Okay. Can you see my screen? Okay. Can you all see my screen? Okay, excellent. So thank you, Dr. Suja, for making me a part of PediSTARS and StepOne as well, the team here. And it's a pleasure to be talking to all of you and actually sharing the inputs that has been an amazing experience for the last 2 months, and the contribution that we all are making as simulation experts is a standing proof what kind of value it's adding to the organization. So greetings to everyone from Dinanath Mangeshkar Hospital in Pune, Dr. Indumati Amudkar Simulation Center as well. This is a 800-bed tertiary multi-speciality center dedicatedly working towards the care of COVID-19 patients at present. The motto of our simulation center has been promoting patient safety culture with 5 S's: skills competence, system thinking, standards quality, shared vision, and support and trust. Okay, so let me change the slide. Okay. All right. So when COVID-19 pandemic set foot in India, the Simulation Center in Dinanath Mangeshkar Hospital, as a team, we all started to plan the trainings. And to plan the trainings, we really need to have many considerations to be thought about. So here, the Simulation Center actively started being a part of the organizational decisions and the policies that the organization was making during the last 2 or 3 months. So every Mondays would be the meeting day, and that's when the center would actually attend the policy meetings and to know what are the updated policies, what are changes being made, what is the government policy that our organization is following. And hence, for us, it was easier to understand what's going on at a big picture level. At the same time, we also wanted to know what's the kind of leadership, because we need to know that one person whom we need to attend and to call for and say, okay, now next, what's that to do? And fortunately, we had a very strong leadership with our medical director, Dr. Kerkar. And under him, there were many leaders as well, leaders dedicated. There's one leader dedicated to clinical decision making. There's one leader dedicated to interacting with the government authorities. There was another for procuring PPEs, N95. So there were multiple leaders and we knew whom to approach if there's a concern. And hence that clarity really helped all of us. Next came the different departments that's going to be involved in the care of COVID patients. Here we had to divide the departments into frontline defense departments, considering ours is a hospital and not a medical college. So the frontline defense definitely were the ER, the ICU, the isolation wards, the swab collection, that the next soldiers need to be ready just in case there are overwhelming numbers of COVID patients coming to a hospital. So the second line defense departments were anesthesia, cardiology, neurology, all the medical disciplines who had a base in medicine could actually contribute and help the frontline defense. Also, there were support departments who were the third line defense, surgical disciplines, which we wanted to rope them in to have supportive like clinical documentation, helping the medicine disciplines to actually treat patients. So we had a 3-tier plan for the departments that were there in the organization. After this, after knowing the need analysis of the organization, is where we focused on the resources that we had. Here, the infrastructure, fortunately, we are pretty much blessed on this aspect because we have 4 simulation rooms, 1 demonstration hall, there are 6 skill stations, and there are 2 auditoriums at our disposal for using. So that was the best part. The second aspect was to have all the simulators and the task trainers. And we do have moderate fidelity simulators as well as n number of task trainers, which was a boon as well. We had to collect lots of PPEs from the leader who was looking after the procurement, and we did get a number from them so that we could give hands-on and trials of donning and doffing to practically everyone who attended. And lastly, but not the least, is the facilitators. The number of facilitators is where, yes, Dr. Suja, you're right. I think we do have less number of facilitators in India as compared to globally. In our center, it is one facilitator, that's me, that's full time. And we do have a part-time full simulation facilitator as well. But fortunately, the department and the organization is waking up to simulation, and hence multiple departments like pediatrics, neonatology, nursing, there are simulation facilitators whom we actually roped them in, and I said, okay, you come in and help us, so we kind of united together and we ran the show. So once the need analysis, the resource checking was done, is where we realized that there are many professionals which are from clinical background and many from the non-clinical background that we need to train. Based on this information that we had, we decided that the trainings that we are going to conduct are going to be interprofessional and interdepartmental, because that's where probably we thought we could get all of them on the same page, and that's how the systems and the departments could be strengthened. So once this was decided, we had to plan the content of the COVID-19 simulation trainings, and the content very much had these 4 aspects. The first one was COVID-19 information, that's transmission, clinical symptoms, high-risk patients, aerosol generating procedures, the treatment options. There's a whole lot of medical information that required to be given, clarify the doubts, update the new policies that were coming from CDC, and hence everybody knew what COVID is. Okay. The second part was even more important, was the prevention of infection. Here we did focus on actual skills of hand hygiene, personal protective equipment donning and the doffing with the help of a checklist, correctly wearing an N95 mask and doffing it as well. Then came the waste management, disinfection. Along with that, we also focused on the COVID protocols of intubation, resuscitation at various levels in the ICU, in the code blue, in the ER, protocols of ventilation. These all actually made the participants much more confident because they knew what they had to do. Okay? So they didn't need to ask every time. They just knew the policy, and those were actually kept as checklists in different areas so they can actually have a visual confirmation. The organization also was kind enough to provide a facility to take a bath after they finished their COVID duties so that they could go home much more cleaner and keep their family members safe. So that was a big help. They also provided residence to doctors who were dealing with COVID patients every day so that they could isolate themselves from their families. The third part was giving authentic information during these trainings, and different departments came to our centers in the simulation center, where it was our responsibility to make sure the information, the guidelines, the policies, the recommendations are authentic, and hence we referred the CDC website, the Indian, American and European Society guidelines. Once we used these, we incorporated in the trainings, and this actually helped the departments to formulate the COVID policies in their particular department and then follow it accordingly. Of course, this policy was also aligned with the DMH, the hospital policy. So they both had to be aligned equally well. So that was achieved in these simulation trainings. The last part was designing scenarios. Of course, there are lots of scenarios that we could get hold of, but then to make them more applicable, they were more tailor-made, they were tweaked to our system so that the changes were made in those scenarios. Some were designed newly as per requirement. What did these scenarios contain? We did test knowledge, skills, decision-making, triage, communication, the COVID policy. We tried them once and twice and thrice till they got it right. Everybody in the team got it right. Telemedicine. We did emphasize on the use of checklist at every point because that was important for them to follow that and make a mental note of it. At the same time, self-protection was the theme of the entire training. I think that really helped all the healthcare professionals to feel, okay, this training is going to keep me safe, so that really motivated them to come back to work. During the debriefing techniques that we used, the reaction phase was something that really made me think, because there was so much of concern regarding getting infected, regarding infected their own families, that the participants did went out, and that's where probably I could sense that, okay, there is a requirement of the training over and over again till this particular concern is addressed. At the end of every session, we would go back to those feelings and we would check whether this still exists. And believe me, there used to be a definite reduction in the feelings, in the fear, the concern, and they felt more confident. I think that's where simulation plays a big role. The techniques that we used were plus delta plus, advocacy inquiry, and of course for the nursing department, I think start scenario, pause, plus delta, and then restart the scenario really worked very well. They responded quite nicely. So here, Dr. Suja wanted me to show the numbers that we did in the last 80 days, starting 16th of March, because the first half of the March we required for training, interacting, finding out more information, preparing our ground. So the number of doctors trained are 415 out of 826. The nurses are 633 out of 1384. Others, which include the MPWs, multipurpose workers, technicians, receptionists, they are approximately 115. The numbers are more than 1,000, but then some of them, because of the fear of COVID, they were not reporting back to work. So we did have a little concern here, but now most of them have come back to work, and that has really helped. The total number here is 1163. The precautions taken during simulation training in the simulation center was something that we really had to work on, because this is in-person training and not a virtual training. The virtual technology is yet to arrive in our lab, and that's in the process. But in the meanwhile, we couldn't wait because the lockdown, though no vendors were available, and hence we thought, okay, we are going to be safe, but how? So we made face masks compulsory for all the participants. As you can see here, the hand hygiene had to be done before they enter the sim lab. They bring no belongings, and especially no clinical care material from the clinical setting to the lab. Social distancing was respected. No respiratory symptoms to any person. If noted, we would request them to stay back and actually report. That was encouraged. Then came the disinfection, which was a very important aspect. Here, we did disinfect the floors with hypochlorite, the chairs with bacillol acid. In fact, we aerated the rooms very often. We cleaned the equipments with soap and water. We could actually, we used all the disinfection policies which we could incorporate. We would keep a gap of at least an hour between the training, so that after 20 minutes or 25 minutes of settling time for the airborne particles, we would do the surface cleaning and then start the next training. So that's a policy that has been followed for the last 80 days, and it has worked really well for us. Fortunately, the air conditioning in all the individual rooms of simulation center, they are not connected to the centralized aircon. So it actually helped us quite a bit. Right. Few of the pictures to share with you for the simulation trainings that we did. PPE donning with checklist on here. As you can see, 3 different types of PPE are used, and all of us could actually experience all 3 of them. How are they worn with the help of checklist. On the right is a PPE doffing, especially into the biomedical waste, which brings to use, and there is a checklist on the side, as you can see here on the board. The next is cluster swab collection. Since our center was a tertiary center, any hotspot that was detected for COVID-19, suddenly a group of 30 patients would come for swab collection, and hence we had to deploy n number of residents and doctors to actually collect nasal and oropharyngeal swabs, and hence a skill training for the swab collection was conducted. Next was closed suctioning of endotracheal tube, which is essentially very important because open suctioning is an aerosol generating procedure. This training was given to the physiotherapy department because they were the second in line defense for the ICU. And since they are aware of the respiratory physiology, they were the best people to understand the requirements and to actually perform tasks that could relieve the respiratory therapist and give them a break if they fall sick or something like that. The simulation center also tested and tried various barrier protection devices that were designed by our clinical engineering departments. And instead of trying on a live patient, they actually tried it on mannequins, how to use an aerosol box, especially for an adult as well as for an infant. There was a face shield which was designed and which can be re-sterilized and could be used just in case the face shields from vendors are not available. We can be self-sustainable in this aspect because COVID is going to be there for quite a while, looks like. So then the slit lamp barriers for opthal department, which could separate the patients from the doctors, that also really helped. And last slide for the day is something that I would really want to share with all of you because this has been highly appreciated by our organization, is the interprofessional and interdepartmental simulation. We actually tested the systems and the resilience of the system. We could determine the latent threats in the system, and then we could actually fix it by changing the policies that were designed. So during the meetings, the inputs from the simulation center were considered, and actually they made changes based on those, as well as departments incorporated suggestions from simulation center. So that was a very big thing for simulation facilitators in our system. Few examples, such as obstetric simulations of COVID positive mother in labor, where obstetrics department, along with the neonatology, anesthesia, nursing, and a lactation consultant came together. So we conducted these all interprofessional, interdepartmental trainings in multiple batches till the primary department of obstetrics were completely covered. So here we had probably 3 or 4 sessions which kept going on, and that helped everybody connect, everybody interact, and policies were strengthened or practiced. Simulation of acute coronary syndrome of a high suspect COVID patients, where cardiology, emergency.
Sorry, Dr. Vaibhavi.
Yes.
Can you just summarize in 2 sentences if you don't mind?
Yes. So interprofessional and interdepartmental trainings really helped make a lot of changes in our system. I think this is my last slide. A helpline for psychological support was developed post simulation of psychiatry department for telemedicine. So that's the end of my talk, and thank you to invite me here. At the same time, I'm proud to be a Corona fighter and blessed to be in an organization which is very supportive and happy to make empowerment of all the healthcare professionals. Thank you so much.
Thank you. I'm just going to share my screen now and just kind of looking at specific points such as what the survey showed in terms of their experience. So in terms of the plus that people actually reported, we had, about the practice of clinical protocols, the opportunity to do that, getting the stakeholders available to refine the process, the low-tech simulation, to be applicable in various in-situ simulation, the Zoom for distance learning in certain centers, especially Canada, and identifying the latent threats, getting the opportunity to rectify them, the high demand for simulation practice, as you mentioned, and the ability to address staff queries through these simulation exercises. Some of the delta or the gaps that was identified was one of the key things that I want to highlight here is the time to wear and also the difficulty in communication whilst wearing the PPE. That was one of the common things. The availability of PPE equipment, the correct procedure of doing it, customizing the COVID equipment, And most importantly, amidst all these changing guidelines, how to do these multiple sessions and availability of facilitators, their time, and the participants. These were some of the challenges that our simulationists expressed. And some key learning points. One of the things that was new was the new code rules and customized equipment specific for this situation. They came up with certain solutions such as using gestures, charts, sign language during PPE. One center suggested about a PPE coach, and then more practice opportunities, multiple location in situ simulation practice, team preparedness, utilization of resources such as videos and distance learning. Um, I want to kind of pause here and then ask Dr. Gitanjali here. So clearly in India, we need to explore other methods to actually, deliver simulation training, especially given the gap in simulation facilitators and and the participants ratio, the availability of resources, both human as well as in the PPE for practice. So from your global experience, Gitanjali, what do you think we should do and what's the way forward for us in India?
Thank you, Sujata. You have given me a very tough task, that is debriefing the Delta. Let me share my screen. On behalf of PediSTARS, I thank each and every one of you for participating in the simulation. And Sujata, yes, we have had our challenges, but all I can say is the future is bright. We learned together in this journey, we shared things, and I think as a community, we have come together more. We have had our challenges. It's not just lack of facilitators or resources, it's a future. What do we do about the non-COVID patients? How do we continue to train our healthcare team? What do we do about the new trainees who just joined yesterday? So these are some of the answers we need to find solutions to. And Dr. Lulu, she's already beautifully given us an example how distance simulation is one of the answers, not answer for everything for this challenge we're facing now in the lockdown. So when I did my simulation fellowship a few years ago in Children's Hospital, Philadelphia, I was very excited to see the telesimulation. And you can see here my colleague Ichiro sitting in the Children's Hospital, Philadelphia. And he's training his team in Japan, thousands of miles away, in pre-briefing, in running the scenario with a sim baby, which is a high technology mannequin, and also debriefing and asking them to help themselves to find a solution. But my take home, can we do it in India? Do we have the resources? And then I happened to visit my little nephew. I saw him playing football with his friends in Africa. And my first thought was, who is not having resources? Is it India or is it a mindset? So I forgot all about it, and then we became very busy doing our simulation in situ and also with our conferences, workshop, faculty development, which is a comfort zone, which we've been doing for years. And all of us like our comfort zone. And then came the fear zone. The little tiny virus, it's managed to scare all of us. Suddenly from zone 3 to 4, we were pushed back to zone 0. How do we train our trainees, the healthcare team? We had no idea. How do we train the others? We are responsible for training, simulation training, the whole country. What do we do? So we're all afraid. And then came a comforting call from Children's Hospital, Philadelphia. Can you do the simulation for the COVID? The pandemic should not stop you from doing the simulation. You're much more than that. And then we started collecting the resources. We took help from our colleagues who are already in the front line, in the war zone outside our countries. And we started creating scenarios. And during the simulation, we can see that there are the major gaps were coming to the WhatsApp group. And you can see here, somebody saying, I think it's Dr. Supraja, 1/3 of our PPE we finished during simulation. What do we do now? And also there is another call from Delhi to say that my residents, some of them are positive. I want to train them all, but I can't train because I can't take my iPad inside. I'm scared. What do I do? Is there some kind of remote simulation? Is there somewhere I can train them remotely? So we try to find resources through Society of SSH, simulation for healthcare, to IPSS, the Inspire. We shared those resources. You can see it's one of the virtual sim or telesim. We made some videos and shared with other hospitals at the Kim's Hospital, Secunderabad. And also, we try to utilize our resources by not using the mannequins, but just using an intubating lung to create a realistic kind of mannequin where they feel that it's a real to practice. And also try to conserve our PPEs. Once a donning and doffing simulation is done, for the other scenarios, we try to conserve and try to utilize our gowns. And our other facilitator, they started supporting each other. You can see here, Mihir saying that, no, you don't have to deplete all your resources. And then we enter the learning zone. The IPSSW was supposed to be held in Florida in April, but we all had to cancel our flights. And then what do? Do we stop training? We didn't. So we had the virtual conference, the IPSS and Inspire. There, the main focus was on how to combat the COVID. So there are various experts who came together in the panel discussion and shown that you don't have to have the high technology mannequin to do the remote simulation or distance simulation. And then we formed a group because there are a lot of things we don't know. So it is just to know what we don't know. And the group is called IPSS Inspire PediSTARS NKS Distance Simulation Collaboration Group. So we're meeting regularly and we formed a focus group to know what's already happened, and also a taxonomy group. Should we call it as a distance simulation? Should we call it as a telesimulation or a remote simulation? So the groups are still working. And the good news is there's going to be a conference in August, distance simulation. You're all welcome to come. And then now we are entering the growth zone. Again, I'm extremely grateful to our guru, Dr. Vinay Nadkarni, who keeps saying, make the impossible possible. So one of the senior team who presented in the IPSS happened to be my colleague, Dr. Elizabeth. So we spoke to her and she came forward to help PediSTARS. So we are just starting some kind of taking some baby steps in doing the non-high technology, but simulation distance. It's at the CMC Vellore. So Aber can sit at his home and try to train his trainers, but use all the software and the real the cases and using the videos. And so that, I mean, the feedback has been really phenomenal so far. So we are still trying to improvise it. Thank you to Dr. Mark Auerbach to come up with this telesim box. And the other thing what we are doing is we cannot just stay in one center trying to see what's happening. And thank you very much to the lateral team, as usual, since 6-7 years they've been supporting us. And now the PediSTARS team have joined hands with the lateral to train the trainers in our country, India, countrywide. We are planning the tele or remote simulation. Again, we are still in the process of kind of trying to find out what works for us. This is my last slide. My favorite person, one of the favorite person in this world, Dr. Abdul Kalam. You have to dream before your dreams come true. So I think our dreams, which were there before, which we tried to be kind of neglect because we were in the comfort zone, now it's coming true because it's need of the hour. So I can say my mantra is for going forward, is collaboration. Don't hesitate to ask for help. Creating innovation and community building. Don't just train your team, try to train the whole community. And to some of your questions, Sujata, I think it's already been answered, how to utilize the resources and empower the nurses, they are assets, and the support staff. We trained all the X-ray technicians, the porters, and the people who are supplying food. So it's not just training nurses, and we know that quite a few have been affected, and we got positive cases because of the food supply in the hospital in one of the northern areas. So we need to train all and share the resources, which our WhatsApp group is doing really well, I can say. Thank you to all the facilitators who are contributing to it. And the key thing, as Dr. Vaibahi said, is a buy-in from the management. And I thank the team IPSS, Inspire, and SSH in providing such a wealth of information to train our team. And you're all welcome to come for the simulation at a distance in August. So stay tuned and let us turn the adversity into opportunity. Over to you, Sujata.
Thank you. Thanks, Gitanjali. And that was a nice wrap up to say that, all this hard work that we've been doing, we've been able to put things across and see how things go, especially for our future. A couple of things, questions that we have now for our panelists. I want to open it up to everyone. So one of the questions we have from Vinay and Ellen Nadkarni is, did you add any new team member roles, say observer or enforcer of PPE to the team? So any of the panelists can answer that.
Yes, we did.
Yeah.
So even for us, I think donning and doffing, especially doffing, is probably more important than donning. The problem in the crisis situation is that, out of your anxiety, you might not wear it properly. So for that reason, we ensure that there is a person to observe how it is worn, and they get a clearance for the person before you enter, and at the same time also have an observer to see that they're doffing appropriately. Yeah. So, I mean, we added that in the protocol, so we did test that in the simulation exercises we did too.
And Dr. Sujata, from our side, like whenever a code blue is activated, the neighboring ward nurse comes and, she becomes the buddy for immediate donning because just before resuscitation. So that's how we were able to kind of bring the time to 20 to 25 seconds. So even we've had a buddy, and also a recorder who stays outside the room. I've shared the picture, and show gestures 2 minutes up. So, the next cycle. So we've had those team members also roped in.
Seem to have answered one of the other questions that we had from Yeri Naidu Komineni was, what is the minimum or maximum time to wear complete PPE in emergency situations?
Okay. On record, my housekeeping staff took 22 seconds. But this is not the sterile, it is just for resuscitation, not the sterile donning. It's just for resuscitation.
I think we had similar experience, isn't it, Rakshay?
Yeah.
The next question we have is from Dr. Ramna Rao for Dr. Rakshay and Dr. Vijay. Basically, share your experience of debriefing and repetition of simulation exercise to reach the desired level of performance. And interested to know if there was any theoretical concept or construct used for these refinements using simulation, say business process modeling.
I will answer the first half off, and I'll leave the second half to the Rakshay. So thank you, sir. We use the mixture of debriefings. So we use the rapid cycle deliberate practice for the skills, because some of these skills are brand new. And whereas for team training, we use mainly a lot of pause and discuss, and also plus delta advocacy inquiry, not much actually for our team. So we use the mixture of them as per requirement. Over to you, Rakshay.
Well, I think Vijay is very good with the business process, so I think he'll be able to answer the questions. I'm not so good, so I can't answer about it. But I guess the objective of a scenario is very important, right? So it becomes more of a zone 1, zone 2 kind of training. So what we have done, like what Vijay said, was more of pause discuss. There were certain times where we might not be the rapid cycle deliberate practice in its entire context, but we use quite a bit of that to ensure that certain critical steps are not missed. So yeah, I mean, it's a mixture of both the pause discuss and rapid cycle deliberate practice is what we use to ensure that certain critical things are not missed while managing unwell patients.
I would like to add something here, Dr. Ramana Rao. Actually, what we did here was the nursing department, we actually trained them before and then brought them in simulation with the interprofessional team. So actually, we wanted them to have a knowledge base, which is a little better, and then come back together with the entire team. That helped us to get all the doctors and the nurses on the same platform of having a knowledge structured approach. So having a small training beforehand and then bring them back again to simulation actually helped.
Thank you. I'm not sure if we have any more questions right now. So shall we just wrap up the session? I want to thank everybody, especially our panelists, all to share your valuable experience. And then your Abhinava events, Project StepOne, Rohit, Shruti, Prajwal, amazing job. Thank you so much.
Thank you.
Thank you all. Thank you, doctors, for your
Thank
time.
you.
On behalf of Project StepOne, I would like to thank all of you.
Thank you very much.
Thank you.
Thank you so much. And thanks, Dr. Sujata, for moderating.
Yes. Thank you all.
Thank you.
Bye.